Okay, so necrotizing enterocolitis. As we know, necrotizing enterocolitis is one of the emergency, the most common emergency or the most common GI emergency. It's the inflammatory disease of the intestine, mainly affected premature infant, and inversely related to the gestational age and the weight. The lower gestational age, higher risk. The lower weight is the higher risk. So 5 to 10% of the premature infant born less than 15 gram. Mortality can be reached up as high as 50% in some centers. As we know, it's characterized by the various damage of the intestinal tract, range from the mucosal inflammation to the full thickness necrosis and perforation. The incidence is varies from 1 to 3, and again depend on the center to center. 10% of the necrotizing enterocolitis, if affecting term infant, usually there's pre-existing illness like congenital heart disease, GI, primary GI disorders, sepsis, intrauterine growth restriction, and very, very careful when you manage baby who's IUGR, always keep in your mind that intrauterine growth restriction, very important risk factors for necrotizing enterocolitis. Or if there is history of the perinatal depression or asphyxia. We know, as I said, the mortality rate up to the 50%, but if baby survived, there is high risk of the long-term sequences like increased risk of the nosocomial infection, malnutrition, growth failure, chronic lung disease or bronchopulmonary dysplasia, and neurodevelopmental delay. As I said, is the most commonly affecting premature baby. The onset, that's very important. Usually full-term baby, if affect full-term baby, usually occur or happen usually early, around 3 days of life. More premature, more later on. So those 60 or 26 weeker and less, usually around 23 to a month age group, where's the necrotizing enterocolitis. So at the time, baby become full feed, everybody get excited because baby is a fetal grower. I want you guys to be aware that although they are baby very stable, there's still chance because at around 20s, that's when the risk of the necrotizing enterocolitis occur in the tiny small babies. In those more than 31 week gestation, usually around 11 days of life. The healthcare cost of the necrotizing enterocolitis in the United States is around 5 billion per year for hospitalization. 5 billion, not million, billion. In average length of stay with necrotizing enterocolitis compared with the other premature infant is 22 days if the medically neck. So the average 22 days or longer if medically neck, up to 60 days if the or longer for the surgical managed necrotizing, and that's published 2012. How the necrotizing enterocolitis histologically looks like. So histologically, it's characterized by the mucosal inflammation or edema, inflammation, hemorrhage, coagulation, and if it's severe, necrosis, and sometimes ulcer or completely perforation. As you can see here in the picture, those bubbling, that's called nematosis. It's the intraluminal air. That's called the, and very clear histologically and very clear cross anatomy or cross picture. You can see the air, bubbling air, that's the nematosis or intraluminal air. For those who are gonna go to the board, you need to know, number one, as we said, the smaller baby, lower gestational age, it's higher risk. So inversely related, that's number one. Number two, you need to remember that usually tiny premature babies, the onset late versus full-term baby, the onset early. The most common site, terminal ileum and proximal colon. Again, terminal ileum and proximal colon is the most commonly affected area. What's the pathophysiology? And we're gonna spend a little bit time on the pathophysiology because it's very important. It's still nobody understands or incompletely understood. It's believed to be multifactorial. Number one, premature. When the baby is premature, the intestinal also immaturity. When the intestinal immature, there is defect in the tight junction or the intestinal epithelial barrier. The immune system or the defense also underdeveloped or immature, and alter the vascular development and the tone of the intestinal mucosa. So that's number one. Plus, the baby, most of the premature baby, they are at risk of some sort of the hypoxia at the beginning. Or if there is any other risk factor with the mom choriomonitis, high risk mom, she's premature, she did not receive steroids, smoke mom, emergency, premature, fetal deceleration, emergency section. So we will describe the risk factors, but if there is source of the hypoxia or most of the premature babies, small, especially the tiny one, they have the ductus arteriosus. And the ductus arteriosus, babies who has the patent ductus arteriosus, usually they have mesenteric ischemia or the mesenteric blood flow decrease because everything is shunting. So when the blood shunting or stealing go to the pulmonary, less blood go to the systemic circulation, including the mesenteric. So less blood go to the mesentery because the blood is going to be redirected to the most vital organs, and less blood supply to the non-vital like the mesenteric. So the baby already have decompromised or they have some sort of the hypoxia, either local or generalized. Then you start feeding the baby. So we discussed about this risk factor. So hypoxia, some sort of the focal ischemia or mucosal damage, whether there's damage or no. You start feeding the baby, especially with the formula. It's non-protective. With the formula, usually proliferate of the bacteria or translocate, we don't know. That's called dysbiosis. We will talk about it. Combination of those factors, plus there is a defect in the prematurity already, defense of the immune system in the babies already, and there's less tight in the epithelial tight junction. There is focal bacterial adhesion to the epithelium, and then bacteria release a product like lipopolysaccharide, followed by the release of the platelet activating factors, TNF, alpha, and that's further breakdown of the mucosa, further inflammation, and end up huge inflammatory markers at that area, and then vasoconstrictions, focal necrosis, and completely breakdown of the mucosal barrier if there is baby is not treated, and then end up to the blood go the bacteria spread to the bloodstream and bacteremia or the sepsis and shock. So that's usually that's what happens. It's multifactorial. There is history plus prematurity plus feeding. The feeding component. The feeding component, as we know, around 90 to 95% of infants who develop necrotizing enterocolitis has been exposed somehow to the enteral feed. So they start with the baby already on the feed. So that's why very rare on baby MBO develop necrotizing enterocolitis. So that's why the feeding is the key here. Plus, it's crucial whether breast milk, as we know, breast milk is the protective, correct? Is the most protective from the necrotizing enterocolitis because of a lot of values of the breast milk. Breast milk contains secretory IgA, the lactobacilli growth increased by the breast milk, and others. The HMO, we will talk about it. The human milk oligopeptide, the lactoferrin, we will talk about it more. But it's very important we know whether baby is a breast, if you take the history or when you evaluate the baby, whether baby on the breast milk versus baby on the formula. Finally, the osmolarity or osmolality of the formula. How much calories baby is on? Is baby on the 20 calories? Very unlikely. Premature babies usually started with 20 calories, and then as we advance, we up to the 24 and 26, and sometimes they need even higher to achieve the growth, which is the 28 calories. So higher osmolarity, it's higher risk for the necrotizing enterocolitis. So those, it's all accumulative, and that's all contributed to the pathogenesis of the necrotizing enterocolitis. Let's talk about the role of the human microbiota or dysbiosis. So that's another very important board question because now the light shiny on that topic. It's very hot spot and hot topic. Board, they love to ask about the rule of the antibiotic use, what happens to the translocation of the bacteria, the normal flora, etc. So we're going to cover a little bit. So as we know, the commensal bacteria that's normal provides several benefits for the human host. The benefits can be maintain the intestinal hemostasis, protect from the injury, support the digestion, and regulate the immune system in the intestine. So those 4 functions is important for the normal bacteria flora or the commensal bacteria that present in the intestine. As we know, at birth, the gut somehow sterile, although there's some study that they say that still it can be taken, or the commensal bacteria, it can be observed that can taken even in utero. But the most important, during the time of delivery, the babies, when they go through the normal birth canal, get colonized with E. coli from the vagina and streptococcal. And that's the normal vaginal maternal flora. Plus, there's some new evidence say also there's transplacenta acquired from the placenta. The normal flora also can become from the flora, from the placenta. So babies start normal, so vaginal versus C-section risk factor. And now we know why C-section risk factor for Nick, because it's less likely to have the normal vaginal flora. The normal vaginal flora is initially small amount. And then when the baby starts on the breast milk has a prebiotics, is the nutrition for those normal flora. So there's difference between prebiotic and postbiotic or probiotic. The probiotic, it's the actual bacterial flora that given. Prebiotic is the nutrition for the normal flora that the baby acquired during the normal process of the normal canal and that or through the placenta, but mainly from the normal vaginal flora. And that's the commensal bacteria, its growth and increase in the number. As we can see, some of the bacteria acquired in utero, and that's the new evidence, although it's not strong evidence yet. We have the mainly from the vagina, the enterobacterial, and more when you give the breast milk. There is those all the HMO, which is a human, that's also board question, a human breast oligosaccharide, fatty acid, IgA is very important, tumor growth factors, beta, and those consider the prebiotics, and as we know, that help the lactobacilli and the bifidobacterial growth. The factors that against it, we know C-section, increase in an unnecessary or the toxic or pathogenic bacteria like staph, corynebacterium. Babies on formula feed, increase the bactericide or the colostrum because you introduce the external pathogen. So there's several factors disturb or dysbiosis, disturb the normal microbiota. Number one, if you give, which is routinely, correct? Routinely, a lot of babies and now people become more aware, physicians become more aware of the risk of the antibiotic use in the premature baby. As a tradition, we used to, all babies premature, we start with antibiotics, ampicillin and gentamicin. And specifically the gentamicin, that can disturb the commensal colonization or the normal bacteria. Okay, so that's why if you have premature baby who born because of the maternal factors like preeclampsia, for any reasons, for any maternal reason, rather than premature labors, even we don't know the GBS, usually we don't start antibiotics unless there is premature contractions or premature labors, or she's been ruptured for a long time. We know that exposure is the risk of infection is higher. Other than that, usually we don't start because of that reason, okay? Prolonged or giving the H2 receptor antagonist. If you guys, whenever who attend my lecture last week about the gastroesophageal reflux and gastroesophageal reflux disease, we spoke about the H2 receptor antagonist. So the acid is one of the immune system or one of the innate immunity the body try to protect or filter. So the acidity is very important for babies. When you give the anti-acid, you decrease the acidity in the intestine, and that's you increase risk of the exposure to the external pathogen. C-section, we discussed about it. If baby already hospitalized, have central line, have any other risk, it might be acquired. And then formula feed. All these can abnormally or disturb the microbiota in the intestine and become from the commensal to the harmful pathogen. The bacteria has been reported for associated with the necrotizing enterocolitis, including E. coli, milligram negative, like E. coli, Klebsiella, Enterobacter, Pseudomonas, Salmonella. And then you have the gram-positive staph, coagulase negative staph. When we said coagulase negative staph, we are connected with the central line induced infection, which is the most common cause of the late onset sepsis, especially those who have central line. Clostridium enterococcus species. Okay, so in general, gram-positive is more common in stage 1 and 2. Enterococcus or the gram-negative enterobacterium more predominantly in more severe, and that's why when the gram-negative, a lot of physicians, they like double coverage for gram-negative because of the how dangerous or how severe it is. Virus pathogen also can relate it to the neck, like rotavirus, coronavirus, enterovirus. Okay, so it's not only bacteria, it could be also viruses. It's unclear whether the bacteria has a primary rules from outside comes, or there's bacterial translocation of the commensal bacteria that's already altered and become dangerous and turn to be pathogenic, and that causes harmful. So exactly, but what we know, around 30% of the necrotizing enterocolitis, when you do blood culture, you get positive blood culture for the bacterial infection. So we already discussed in brief about risk factor. Let's focus on the risk factors. The primary risk factors we already discussed: the prematurity, dysbiosis, intestinal dysbiosis, and formula feed. Those is the board question. The board, they like to ask about those three. Either they bring intestinal dysbiosis in the board, and I think I saw one of the other board question. Prematurity, and they love to used to, I don't know nowadays, but they used to ask about formula instead of breast milk. So those three consider as a risk factors. The other maternal risk factors increase with the chorioamnitis, if the mom cocaine, vasoconstriction, ischemia, cocaine or drug abuse. If there is IUGR, also always IUGR, keep it in mind, okay? Increased body index or obesity, cholestasis during pregnancy, lack of the steroid. Steroid is considered as a protective. We will discuss about it. Placental abruption, preeclampsia, they all decompromise the placenta, smoke history. The postnatal risk factor, which is cover majority, acid suppressant medication, perinatal hypoxia or acute hypoxia, low Apgar score during delivery, severe metabolic acidosis, which is a lot of premature baby, they will have some sort of metabolic acidosis early in the time of the delivery, like hospital course. Either related to the ducts or not ducts related, renal tubular acidosis, etc. Antibiotic exposure, we discussed about it. And then others, if they have cardiac anomalies, if they are poor or they have some intestinal perfusion, poor perfusion, either secondary to the ducts arteriosus or secondary to the other factors. So just to very quick, I know people, they like when we draw a picture or just about the ducts or bore. So we discussed a brief, that's the heart. We have the right here, the left atrium, left ventricle, right ventricle, right atrium, the aorta, pulmonary circulation, and here you have the ducts, the lung, and then back to the pulmonary veins. And that's the aorta. So if you have 100% of the blood coming here, oh, let's do the blue. We know that the blood, when you have a large PDA, the left side of the heart is dominant after birth than the right. So the blood is going to go diverse or stealing, go to the right side of the body. So less blood supply to the systemic circulation. When the less blood supply to systemic circulation, then it's going to be redirection of the blood depend on the vital organs. And one of the area that decompromised during the large duct arteriosis or significant duct arteriosis is the mesenteric. Okay, and that's decrease the perfusion. Indomethacin use. We know indomethacin for the ductus arteriosus also can be a risk factor. So indomethacin or the non-steroid inflammatory drug can decrease the mesenteric blood flow. That's why some centers, they keep baby MBO and they hold feed during the ductus treatment, like either indomethacin more than ibuprofen. So for the ductus arteriosus, we have indomethacin, we have ibuprofen, or we have the acetaminophen or the tylenol. The most common use, or not use, the most common cause mesenteric ischemia or can cause the spontaneous bowel perforation is indomethacin. Second, ibuprofen, less or newly now medication, the acetaminophen or the tylenol or the Panadol IV, okay? The indomethacin cause vasoconstrictions in the kidney and in the mesenteric. So some centers, they hold the feed. There's no evidence. In my centers, in other centers, they keep the baby on the trophic feed because based on animal study, when you give indomethacin and during the baby's already feed, as we know, when you eat, you increase blood supply to that area. Your stomach, you feel like you are dizzy, you are full. So that's what happened. When you give indomethacin, you reverse, by the feeding the baby, you reverse the vasoconstriction effect of the indomethacin, and that's based on the animal study. So that's why in my center, when we start baby on the ibuprofen, we don't use indomethacin, but when I trained, we used to use it. So some centers, they just hold the feed. In mine, we go down to the trophic, we leave the baby on the trophic feed during the treatment of the ductus arteriosus, okay? It's very important also, the hot topic, anemia and red blood cell transfusion or transfusion-associated neck enterocolitis. That is very important topics. I trained in University of South Florida with Dr. Maheshwari. He's big name on the necrotizing enterocolitis, and that's the main study focus on the animal studies and necrotizing enterocolitis, anemia, blood transfusion related injury. So really nobody knows. Their study showed that the blood transfusion babies they receive blood transfusion, they're high risk for necrotizing enterocolitis. Subsequent study, they highlight the rules of anemia. Most likely still ongoing studies, but most likely the degree of the anemia caused the mesenteric vasoconstrictions, because babies already adapt. We usually like aggressive treatment. We don't transfuse that often unless baby symptomatic or there's certain very low the hematocrit. And then you transfuse reperfusion, and that's release the inflammatory markers, and that's what caused the necrotizing enterocolitis. That's the most likely explanation, that degree of anemia first, and then the trigger is the blood transfusion. Blood transfusion loss is this new studies. Blood transfusion loss is not, they did not support that as a risk factor as alone, but maybe the degree of anemia first, vasoconstriction, and then you transfuse the reperfusion injury, and that's what caused necrotizing enterocolitis. Hopefully the picture is clear. How baby presented the necrotizing enterocolitis? Usually it's subtle, correct? So we need to know that when you have a baby with necrotizing, true necrotizing enterocolitis, is very quick. Baby is completely well to dying. So it's very, very fast. The hospital course or the course of the illness is that's why you need to be very aware of the symptoms, and you have to react very fast. Don't wait until you have the full pictures, okay? A lot of the what we do, it's not true neck, but because we need to react fast. That's why whenever you have increased abdomen or fetal intolerance, increased abdominal distension, some tenderness, decreased bowel sounds, if you notice bloody stool, make sure you examine the baby, make sure the anus, there's no anal fissure, and then you are look at the other picture, because also there's multiple causes of the bloody stool. It could be intolerance, cow milk protein intolerance. It could be true neck. We don't know, correct? Sometimes history of the bilious. If you see bilious vomiting, surgical till improve otherwise. Temperature instability as a septic babies can be present with the jaundice, increased events of the apnea, bradycardia, DSAT, and as I said, they can present it very quick to the shock, septic shock presentation, and circulatory instability, hypotension. Okay, so don't wait for all these symptoms. It's too late. If you wait for all these symptoms, it's too late. I'm guarantee you, baby's dying. So in the moment that the baby has some emesis, abdominal distension, plus minus stool, you need to react. You need to keep baby, investigate what's underlying cause, and sometimes you need to keep baby MBO for bowel rest until you figure out what's going on. So let's go over normal abdominal exam versus abnormal. The normal, as we know, it's soft, not tender. There is no bilious aspiration. There might be spit up, as we discussed in the reflux. It's very common. Almost 100% premature baby, they have some sort of spit up or the regurgitation. Usually the colors, so those in the description here, it's normal color of the emesis. The light white, clear white, or milk, it means, or light yellow or greenish thing, that's normal. Once become more dark greenish, lemon or avocado or spinach, that's more abnormal. Bowel sound usually present in the exam. There is no dilated visible loop. Dilated visible loop alone, it's not an evidence or not the indicate is not mean baby has necrotic colitis, but sometimes baby CBAB belly can give you dilated visible loop. So that's why you need to look at the whole picture, and baby should have normal vital sign. That's normal baby. In other side, baby with feeding intolerance, either because of the cow milk intolerance or the necrotizing enterocolitis, examination is very, very important with the history and exam. If they told you that baby has bilious aspiration or emesis, one of the trick we need to look at whether your feeding tube, either orogastric tube early or late. If baby has the NG tube is deep, you need to adjust it. If it's not deep, then you look at the other symptoms, the abdomen, how the abdomen looks like. If it's fair, discolor, tender, sometimes it's tender is hard. Baby's gonna cry either way, so you need to be careful about the word. Significant abdominal distension, visible loop, absent bowel sound, that's indicated there's something going on, something wrong. As I said, bloody stool, it could be indicated of the anal fissure or formula intolerance or cow milk intolerance, but if with other picture, it might be indicating necrotizing enterocolitis, okay? Aspiration, gastric residuals, inshallah, I will give another topic about the feeding in general and check for the residuals. We don't check anymore for the residuals, but for those who use they check for the residual as a part of the routine hospital care. If more than 50% residuals, then you need to consider as abnormal. What's the lab finding with the necrotizing? That's another board question. I'm gonna highlight it, but I'm gonna mention all of it, and then I'm highlighting the most common, okay, or most commonly used in the board. So you have to think of three. You need to remember as a trigger of the necrotizing enterocolitis. If you have thrombocytopenia, acidosis, hyponatremia, then you need to be aware that baby might be early detection or not early, but might be an indication of the necrotizing enterocolitis. Again, thrombocytopenia, metabolic acidosis, hyponatremia. Why hyponatremia? The capillary leak, third spacing. Okay, so again, thrombocytopenia, low platelet, acidosis, hyponatremia because of the capillary leak. Fluid go to the third spacing. Okay. Thrombocytopenia, as I said, CRB as an infection. Usually neutropenia in small baby for infection. Usually neutropenia more than leukocytosis. Anemia. Positive blood culture, as I said, but negative doesn't mean anything. Positive blood culture in 30% of cases. Metabolic acidosis in severe, they can go to the DIC, abnormal coagulations, increased kidney functions, BUN creatinine, hyperkalemia because of metabolic acidosis and infection severe degree, and hyponatremia. So be aware, or I need you guys to keep an eye on the thrombocytopenia at the board for those interboard, hyponatremia and metabolic acidosis. Okay, differential diagnosis. It's very important to know that one of the differential, especially if occur early, it's the spontaneous bowel perforation. If you have premature baby who presented with severe abdominal distension in the first week of life, with introduction of the feed. Or no, it might be history, it might be no. If the baby is already on feed, usually those history of the starting feed, baby all of a sudden become abdominal distension. You do X-ray, you find baby has a perforation. There is no nematosis in the stimulus. So there's no submucosal air. Just you see it's ruptured bowel. All of a sudden, baby's completely fine. Either you start feeding or baby's all of a sudden from nowhere, you find baby has the abdominal distension in the early first week of life. That's most likely spontaneous bowel perforation. And usually baby is not as sick as necrotizing enterocolitis. It could be other differential diagnosis. So spontaneous bowel perforation, if you find baby is premature, who has a PDA, start medication, and then they found abdominal distension, you think of that spontaneous bowel perforation as an early differential diagnosis, okay? Late, think more with the necrotizing enterocolitis, but sometimes overlapping. So nematosis, intestinals, that's a clue. Infection, it could be virus, it could be bacteria, just ileum. It can be surgical cause, babies throw up, abdominal distension, surgical cause, volvulus, intestinal malrotation or volvulus, that can be a cause. Or baby septic, as I said, is ileus. Another differential diagnosis is cow milk protein allergy. Sometimes it's very hard, especially at the beginning when the baby, as I said, usually you need to be very low threshold for NIC. So sometimes overlapping pictures, baby abdominal distension, emesis, loopy bowel loop, distended bowel, bloody stool. You start immediately, hold the feet. You don't know what's going on, so you treat it as a NIC till improve otherwise. And then if the baby's everything came back stable, there's family history, there is labs benign, then especially if there's eosinophilic, then you think it could be cow milk intolerance, then necrotizing enterocolitis. So that's another differential diagnosis. Very, very rare. You have the neonatal appendicitis. Radiological images, it can be a question too. They can give you a picture and you need to diagnose. Non-specific or suspected NIC, it could be dilated loop, just thick wall and dilated loop. Further, once you suspected, part of the suspected, you take out from the suspected, is now most likely mild. You see the nematosis intestinals. We will see it. It's up to the 70 to 80% of the confirmed case of NIC. They have nematosis, which is bubbling or interluminal air. Be aware that sometimes not sometimes, always look at the liver side for any portal vein, because of the micro leak, sometimes micro perforation, the air escape and then go to the portal vein. And then you see it on X-ray on the liver, should be the liver's white. If you see the black, like tree-like, that's our branches, linear branches, that's the called portal venous gas, and we will see it. And then finally, if perforated, that's the pneumoperitoneum. For those did not follow my serial lecture on the respiratory, I gave a lecture on the air leak syndrome. One of them is the pneumoperitoneum. So this is the X-ray. So if you look at this X-ray, you can see it's the non-specific. It's already dilated loops, but more than just dilated loop, you can see the loopy. But here you can see these lines and more on this side. That's called the nematosis intestinals. Okay, intraluminal air. You can see there's internally. It might be here too, but sometimes is baby clinical stable. There's overlapping bowels with the stool. Sometimes stool can give you a false picture of the nematosis intestinals. So the clinical correlation is important. If you look at this one on the liver side, you can see that's the portal vein gas, okay? That's the very important. That means there's micro perforation. Other sign of the necrotizing enterocolitis on the X-ray is the football sign. So you can see in the liver, there is ligament called falciform ligament. So if you see the air in between, falciform ligament, you can see falciform is very clear. That's the football sign, and that's indicated necrotizing enterocolitis, the perforation. Okay, air around the falciform ligament is very important. I need you guys to look at a lot of images. You can see this also might be there's some air here. Okay, so that's why those babies need lateral decubitus X-ray to look at if there is any nematosis. And usually we do lateral decubitus, left lateral. We leave the left side down and the right side, because the right side deliver. So you can see if there's any air, you can see it here, okay? Another sign called the regular sign, and that's the double wall sign. You can see another, so they can see here. So there's the line, very clear. And that's another line. So that's called regular signs, or the double wall sign. Also can be represent intestinal perforation. The air in both liminal and the peritoneal side. For either spontaneous bowel perforation or necrotizing, it might be, you might see the perforation. So either you see the air under diaphragm, another clue, you might see it on the right side, or you might see it on the left side. You can see there's air under diaphragm. If you put baby on the lateral, left lateral decubitus, you can, or cross table, you can see the clear air up here, okay? And that's the pneumoperitoneum. You can see the air around, circulating around the baby belly. Okay, so Bell's staging criteria for necrotizing, and there is modified Bell's, so I'm gonna cover modified Bell's criteria. So suspected necrotizing enterocolitis, temperature instability, baby has a multiple events, Brady, apnea, that's systemic signs, intestinal symptoms, non-specific, maybe occult blood or maybe no, normal X-ray or mild ileus. You are not sure what's going on. You hold the baby because there's mild abdominal extension. The nurse, she told you there's increased abdominal girth, non-specific. There is dilated loops. You do X-ray, non-specific, or there is mild dilatation. Keep baby MBO, antibiotics for 3 days. And that's called the stage 1A. Stage 1B is the similar, but more cross bloody stool. And that's also, it could be necrotizing, or it could be cow milk intolerance as a enteritis. So in this case, you just hold the feet, keep baby MPO for 3 days, reevaluate baby. Baby completely resolve the picture and stable, CBC unremarkable, or there's some eosinophilia, there's history of the, then you know that's most likely cow milk protein intolerance. If the, or sometimes it's just ileus. Stage 2A, it's mildly or definitive necrotizing enterocolitis when you start seeing nematosis, intestines, or the ileus, but mainly nematosis. Once you see the radiology report of the nematosis, intestinals, that's the definitely mild or higher. So stage A is the same pictures, but plus or minus bowel sound absent, and nematosis intestinus. Those, whenever you have it, then you have to keep baby MBO, and antibiotic for at least 7 to 10 days. Moderately ill, baby mild respiratory or metabolic, acidosis, plus minus thrombocytopenia. The same picture on the abdomen. Here you can see microperforation, or just nematosis intestinus with metabolic component, acidosis, thrombocytopenia. Then you know that is moderate than just mild. In this case, you need to treat for at least 14 days. Advanced or severe, that's more clinically ill. Baby might have ascites, completely sick baby. Those babies that has all metabolic and symptoms there. Once baby in the perforation, then it's already severe stage 3B. So if the baby already have perforation, that's stage 3B. If baby severe sick, but there's no perforation, that's the stage 3A. If the baby just mild symptoms, there's portal vein, mild to moderate, sometimes it's overlapping, but at least I need you guys to be aware. Once you said neck, or there is nematosis intestinals, plus minus lab finding, in this case, you need to involve early the surgery. You need to keep them aboard. So you need to let them know, hey, they're not going to do anything, but they have to come evaluate the baby. At least when you call them because the neck usually rapidly deteriorated, when you call them, they're already aware. They're not going to read the whole, they know what's going on, and they keep following with you. So we don't call them at the end when it's already perforation. Unfortunately, if there's already perforation that you are not expected all of a sudden, then yes, but prefer to call them early so to be aware and they stay on board. How we treat necrotizing enterocolitis. So airway, secured airway, ABC. Monitor breath if the baby, because baby has abdominal extension, so you don't want to bump air maybe on the CPAP, or usually those babies very sick, lethargic, poor perfusion, so you need to secure the airway, and you need to decrease the air like farther abdominal extension or the farther CPAP belly, so you need decompressed. So MBO, you place something called the blogo catheter, which is big feeding tube, it's bigger ones, and connected with the suction, so you can suck all the air. The whole idea of the suction to decompress. So you take all the air, so hold the bowel rest. That's number one. And then you secure, if baby has airway issues, always is good to secure the airway. Circulation, you have to have 1 or 2 IV access, because as I said, especially if you know that's through neck, you need to at least 2 IV access, because those babies are rapidly deteriorated. If they need volume, you need to give them volume, or if they have hypotension, you need to give them, is not only volume, sometimes you require vasopressor. The antibiotics. So the question is, what's the antibiotic? What's the bacteria that we know we should cover? And what's the most commonly antibiotic we should start? So the antibiotic, it varies from one center to another. We know up to 30% of the necrotizing enterocolitis have the bacteremia or positive blood culture. So don't wait for the blood culture to turn positive to start antibiotic, correct? Because as we said, this is the necrotizing enterocolitis, one of the most common emergency, GI emergency, or the commonest GI emergency, and carry higher mortality up to the 50%. So you need to start immediately antibiotic if you are dealing with necrotizing enterocolitis, or even suspicious of necrotizing enterocolitis. You start with antibiotic. The antibiotic coverage, you should cover 3 organisms. You should cover gram-positive, gram-negative, and anaerobic. And specifically anaerobic if you have perforation, but you're not going to wait for perforation to cover. So that's why sometimes, as I said, there is microperforation. So it's better to cover. The most commonly, it's based on the local resistance pattern, and that should be taken from every hospital. They have the antibiogram. That's the guide which the bacteria commonly available in the center and resistance to that pattern. But overall, I know Libya, we don't have it. So overall, we should cover. So we need to, Dr. Ayman, remind me again, what the antibiotic you guys use in Libya for the necrotizing or suspected necrotizing?
Broad spectrum antibiotic, usually Mironam, vancomycin, and Flagyl or clindamycin.
So let's say, so you said Mironam plus vancomycin plus
Flagyl or clindamycin.
Clindamycin. So okay, so that's a little bit I can say aggressive management, or we don't use Mironam unless they be very, 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 very sick. So usually, and plus Mironam, so we need to know Mironam is the 4th generation cephalosporin. It has good coverage against gram-negative. It has good coverage against anaerobic, but it's not good for the Enterococcus. So Enterococcus, unless the ampicillin sensitive strain, it might be fecalis, but not all species of the Enterococcus. So we used, and at least the centers that I trained here in America widely used the Zosyn. Zosyn is the piperacillin and tazobactam. Okay, so beta-lactam plus tazobactam, or piperacillin and tazobactam, called Zosyn. Zosyn has widely cover against gram-negative, gram-positive, and a good cover also for the Enterobacter or Enterococcus, sorry. The exhibit for certain species, which is like the resistance, sometimes you need to add something. So either Zosyn alone, and that's what we use, only one antibiotics, because it covers all these. If baby has central line, and you think of the central line, if baby has central line, you think of the staph, coagulase negative staph, then usually we add vancomycin. So again, Zosyn and vancomycin, that's the widely used. but doesn't mean that the others is wrong. So you can, what Dr. Ayman said, you can use, so every hospital they have, so I don't want you guys to change the bathroom, because unfortunately there's no antibiogram in your local hospital, so we don't know, so it's better to cover than sorry. So the whole idea, the antibiotic that Dr. Ayman mentioned, merobenam, that's cover gram-negative mainly, and anaerobic also, and gram-positive as well. He add the vancomycin for mainly staph, coagulase negative staph, plus to add another coverage for anaerobic, he add the metronidazole or clindamycin. That's the comprehensive coverage for all the possibilities. So every center they use it different. Some centers they use merobenam and gentamicin, or merobenam and metronidazole, merobenam, vancomycin, and but majority of United States, at least that I'm aware of, maybe I'm wrong, but because I didn't work in all the hospitals, but at least the places that I trained and the places I'm work currently or used to work, they start with the Zosyn because it has a very good broad spectrum coverage. And if the baby has central line, they add vancomycin. Okay, if you think a baby, so that's the most commonly management use. The other supportive therapy is very important. It's not just antibiotic and forget about the baby. It's very important for the electrolyte correction, especially hyponatremia, hyperkalemia. If the baby has any electrolyte imbalance, you need to correct it, treat coagulopathy if needed, and pain control as well. How often we need to do the electrolytes since after the first. So we said that we're going to do first time. We're going to do CBC. We're going to do complete blood count, that including the urea function, that's including the electrolytes, liver functions, and also we do the gas, as well as the serum lactate level. If the baby, and then usually around 12 to, we repeat the lab 12 to 24 hours, but earlier if you think baby is getting worse and you're concerned about hyperkalemia, because they might severe metabolic acidosis can cause severe hyperkalemia, and that's end up arrhythmia. So you need to be aware that hyperkalemia can add another risk, or can add another dangerous values in treatment. So, and what about the image? Okay, and you did the first image, you suspected necrotizing, or there is early nematosis intestinal, then you might need every 6 hours, or 6 hours to 12 hours, and maybe even earlier if baby clinically deteriorated. Okay, so that's we cover, and we said that usually 6 to 12 hours you do the x-ray depending on the clinical, and then maybe even earlier. Surgical management. Surgical management, we know, is around 30 to 60% chance that baby might be in the surgery. So very, very important to be low threshold, aware the team as soon as possible. Once you are diagnosed NIC, it's better to give them a call and keep them on board. There is 2 surgical options. Depend on it's depend from center to center, depend on the physician's preference, pediatric surgeon preference. But overall, the general rules, if the baby clinically unstable, if the baby very unstable, to move the baby to the OR, then you need to do the drain. The primary peritoneal drain, or the Penrose drain, and I will show you guys. So that's what does mean, it decompressed. So just they place the rubber, they call Penrose drain. Okay, they make a small hole and they put this balloon drain all the way, so at least all the air, whenever the air come out, anything come out, so it's going to be like decompressed. Okay, because you don't want to be like the air start compress the other organ and then further ischemia, so you need to decompress and then wait until baby is still stable and they reevaluate. If the baby is stable enough, if let's say your baby has a perforation, bowel perforation, and baby very stable, especially spontaneous bowel perforation is very stable baby, then you can take them to the OR for the X-lab and then look at the organs. If there is any deadly or necrotic organ, you can take it away, and then osteomy and fistula, okay, or the just anastomosis. But because of the lack, so the most commonly and prefer procedure is the laparotomy. Take the baby and do the X-lab, correct? So open and see what's going on. But because that's the most effective, sometimes it be unstable. So you commonly, especially if the baby is unstable, they do, especially tiny babies, premature baby, usually when they get necrotizing, they are very unstable, or spotted bulb perforation, very unstable and very tiny. They place the Penrose. So due to lack of the data, the choice based on the clinician or clinical experience, based on the preference from the surgeon and from institution to another institution. There is absolutely indication for the surgery. So whenever there is pneumoperitoneum, that's the immediate, either laparotomy or Penrose drain. The second, it might be also as an absolute indicator, if the baby, you maximize the medical and the baby is clinically continue to deteriorate, you discuss with the surgery and say, hey, this baby is clinically like getting worse and worse and worse, then at this case, I think it's better to X-lab and see what's going on, okay? The relative indication, if the baby is getting not severe, but at least the abdomen, despite the medical, abdomen is get distended. If there is baby concern of fixed loop, intestinal loop, if there's portal veins, thrombocytopenia plus minus, those are relative. But the really indication, once you have the pneumoperitoneum, that's the true indication. The complication of the necrotizing enterocolitis, acute complication, sepsis, meningitis, peritonitis, or abscess formation. Sometimes the stool coming out and that's create abscess. I remember 1 or 2 cases that we treat. Babies already on the good coverage of antibiotic, already on the Zosyn, already in vancomycin, and still enterococcus. We treat the baby still the same. We are like, what's going on? We treat babies like the still blood culture positive, still blood culture despite the good coverage. Then we call the surgery. I think there's something wrong. Baby's 3 times blood culture is positive. They have to do X-lab because sometimes what happens, baby has abscess formation or the drain, the stool outside, and sometimes tiny enough, not enough to cause the aware to see the air outside. So that's the another factors that need the surgeon to open to just clean the area and then make sure there is no perforation or bowel ischemia. Sometimes with necrotizing enterocolitis, they might have the, even after treat, they might have thrombocytopenia. Sometimes it takes time to resolve, so that's be aware. So DIC also can be a complication. Acute respiratory, acute or cardiovascular complication, hypotension, septic shock, or respiratory failure. That's another metabolic, as we discussed, severe metabolic acidosis, hypoglycemia, hyperkalemia, and sometimes even arrhythmia from the hyperkalemia. Late and the most common, and that's another board question, the most common late gastrointestinal complication of the neck, intestinal strictures, and short bowel syndrome. Again, about the most common GI, I'm talking about GI, the most common GI complication from the necrotizing, and that's for those study for the board, write it down, intestinal stricture and short bowel syndrome. Here, summary of the incidence of each one. So we already covered the majority, and there is small chance, 4 to 10%, that especially for medically treated neck, they can be recurrence, especially for those that have congenital heart disease, they might have a recurrence of the necrotizing enterocolitis. Then now we already discussed about treatment, we discussed about underlying cause, how we prevent steps for the necrotizing. Number 1, steroids. We mentioned steroids, although we give antenatal steroids or perinatal steroids, betamethasone mainly to protect against the acute respiratory distress syndrome. But also the study showed that antenatal steroid reduce the risk of the necrotizing enterocolitis. The mechanism is still unclear, but it might be related to the decreased inflammatory mediator. That's number 1. Increase the activity of the enzymes involved in digestion and absorption, and potentially the maturation of the microvilli membrane. So make sure, and unfortunately, those premature babies, sometimes they come very quick that there's no time to give steroids. So when you have those babies, consider risk factor, not only for chronic lung disease and respiratory, also for necrotizing enterocolitis. Feeding. As we discussed, always we encourage maternal breastfeed, maternal breastfeed, maternal breastfeed. If you don't have maternal breast milk, I know you guys, you don't have it, but we have something called donor breast milk. Donor breast milk, it's available, and we recommend over the formula. The breast milk, we know that reduce the risk of RIC, lower the gastric pH, enhance the gastric motility, and has a probiotic secretory IgA, lactoferrin, oligosudose, all probiotics, oligosaccharide or HMO that lower risk of the extensive microbial dysbiosis, and an important risk, which is the important factors for the necrotizing enterocolitis. As we discussed, osmolarity, hyperosmolar can be a risk. Try to avoid the hyperosmolar unless it's needed. Try to treat if there is any polycythemia, because increased viscosity also consider risk factors. Avoid unnecessary and prolonged use of antibiotic. I know in Libya, unfortunately, we are misuse the antibiotics. So I need you guys to be aware, and that's another purpose of this lecture, to be aware of the risk of the antibiotic use. Even in full-term baby, now in the many places in the United States, we use the Kaiser score, and I think the next another lecture we will talk about neonatal sepsis. I think brother Dr. Ayman, he with one of the visitors I was there also, we discussed about neonatal sepsis, but I will give a separate lecture. But we know that with using Kaiser scores for the full-term baby, we reduce the chance of misuse the antibiotics, and more if we use it for the Kaiser is not purposes for premature babies, but if you have premature baby, the reason for C-section or reason for delivery, it's the maternal cause, preeclampsia, whatever the cause, then no need for routinely use even though baby or respiratory support. Try to not misuse the antibiotic use for that purposes. Avoid the agent that reduce the gastric acidity. Avoid use H2 receptor blocker or the proton pump inhibitor or the reflux. Reflux is very common. Up to 100% of the premature baby, they have reflux. So reflux itself, we shouldn't treat it because you're going to reduce the gastric acidity and increase the risk of the sepsis. Avoid severe anemia. Follow the guidelines. Whenever the guidelines you guys have it, you need to follow guidelines. There is very clear guidelines that we follow based on the age, based on this respiratory, whether baby requires respiratory support or no, and based on the degree of the anemia. So follow the guideline, but overall avoid severe anemia. But also, I don't want you guys to go a little bit anemia, let's transfuse. No, also the blood transfusion is not good, okay? So be balanced. Avoid severe hypoxemia. Not routinely recommended because not enough evidence as effective to prevent necrotizing enterocolitis. Use the immunoglobulin, oral supplement of immunoglobulin. We don't use it, just written in the literature. There's one randomized study showed that protection against necrotizing in premature baby when they use combined IgG and IgA preparation. But recent Cochrane review look at 5 studies about using immunoglobulin supplement. They found there is no difference between the no significant difference in the NIC or death from the necrotizing enterocolitis with either IgG alone or combined IgG and IgA preparation. For record, there is no randomized controlled trial have been evaluated IgA preparation alone. Probiotics. Probiotics, there is good evidence support the use of probiotic therapy to reduce necrotizing enterocolitis. In the United States, some center they use it, some center not use it. Overall, there is not recommended. It's probiotic. We said prebiotic, that means nutrition. Probiotic is the actual live microorganism, mainly Bifidobacterium and the lactobacilli. It's prepared, mixed with the milk, or it's already mixed. You give it to the babies, okay? That inhibit the pathogen adhesion, strengthening the tight junction that we discussed, down-regulate the immune or inflammatory response, and stimulate the expression genes encode for the immune protection factors, like such as the immunoglobulin A by the toll-like receptor. Toll-like receptors, they have a big rules on the necrotizing enterocolitis. I don't want to go in details, but toll-like receptors, that's the very, very important factors when the normal bacterial flora triggers the toll-like receptor in the in the epithelial layers that stimulate the cascade membrane, that's help the immune system and help even the repair of the epithelial tissue. But when there's no signal, or when disruption it doesn't signal, especially in animal studies show that when you disrupt the signal on tool like receptors, that's cause damage and that's create necrotizing like pictures. So there is recent study evidence suggests not only probiotics, actual bacteria, you have to give it live organism, even piece of it, like bacterial products such as tool-like receptor ligand or the CpG segment of the DNA, piece of the DNA, can be effective in the decreased inflammatory markers in the intestine. Okay. As I said, in the United States, it's not still overall is not recommended. Number one, because the preparation, there's like you have to mix it, so the risk for the bacteremia, lack of the optimal strain and the dosing regimen. There's absence of quality control regulations, and also necrotizing stress overall in the United States is low. Okay. Lactoferrin, that's one of the board. They love the lactoferrin for the MSQ. So for those preparing for the second part board or the first part, lactoferrin you need to know. So lactoferrin is the iron binding glycoprotein. So that means glycoprotein, they love to bind with the iron, and the bacteria eat iron. So when you the glycoprotein collect all the irons, they help decrease the or kill the bacteria. So that's the iron binding glycoprotein and component of the mammalian innate response to the infection, and has been used prophylactic against prevention of the necrotizing. Okay. Its majority presented in the colostrum and the breast milk. So it's a major whey protein. As we know that the main protein in the breast milk, and we discussed last lecture, is whey protein. We have casein and we have the whey. The formula, it's 60 to 40, 60 casein, 40 or 30 whey. In the breast milk, just remember, whey breast milk is way better. So whey protein, that's another board question for those for board. So the lactoferrin, that's the major whey protein in the colostrum and breast milk. It's iron binding glycoprotein. That's the board. Iron binding glycoprotein. Just okay. It's not routinely recommended as a routinely used to prevent necrotizing because not enough data demonstrate strong evidence benefit to use. HMO, another very, very board want you to know what's HMO, and that's you can find a lot of article about HMO. HMO is long chain sugars. Okay, it has more than 105 components, different type. HMO increase that's the intestinal cells, that's the goblet cells, increase the goblet cell and also mucin expression and stabilize the barrier of the mucosal intestinal membrane. The multi-center, human cohort study, they analyzed the mom's milk. They found those baby developed NEC has lower level of the specific class of the HMO than controls. That's why it's raise the rules of HMO in the necrotizing. So enterocolitis. HMO is very important and has good, and breast milk has a good amount of the HMO. So that's why it's highly recommended, and we highly recommend HMO in the mom's milk. Glutamine versus the arginine. So glutamine is an amino acid, has been shown it's important for the immunity and intestinal or epithelial regeneration. There is two large trial to use the glutamine and to decrease the necrotizing enterocolitis. Those two multi-center trial did not support that glutamine supplement can decrease the risk of the necrotizing enterocolitis. The arginine also is the substrate for the nitroxide production. What does mean? So that's I don't know if I know in the USMLE, the NICU board, they ask for it. So as we know, the arginine can give you citrullamine. And that's you guys, you need to know this because that's one of the urea cycle. And the end product is the nitroxide. And nitroxide is very vasodilatation, so it's a precursor of the or substrate of the nitroxide, and demonstrate the effect. They give vasodilatation effect and has also anti-inflammatory properties. Okay. Although the initial study or the initial results suggest that arginine supplement may play a role in protection, but recent Cochrane did not have any conclusion, and they said further study needed because it's not enough to recommend it, strong enough to recommend it use as a supplement. And that's the, okay, I don't know that I have it. Okay. In conclusion, so necrotizing enterocolitis, as we said, is the one of the most common and devastating gastrointestinal disease affecting premature infant or those less than 1500 gram. Is the most common emergency, GI emergency. The main factors related to the necrotizing enterocolitis, prematurity and formula feed and alter in the or dysbiosis or alter in the normal bacterial flora. Premature intestinal epithelial is predisposing to the or because of the premature intestinal epithelium, the already intestinal epithelial is the tight junction is leak and immune response is less, and in addition to those factors combined, in addition to the impaired gastric or mesenteric perfusion, all these can contribute to the necrotizing enterocolitis. It's very important to know that necrotizing enterocolitis, you need, once you think about it, you need to react. It's like a meningitis. When you think about it, you need to prove it or you need to treat it. The same necrotizing enterocolitis. So once you think about it, you need to react. So KBB-MPO, decompression, reblogal, which is large tube, feeding tube, large one, decompression with low intermittent suction, and then try to start antibiotic. The most common antibiotic coverage, you need to cover the gram negative, gram positive, and aerobic. Be aware that if baby has central line, think of the gram coagulase negative staph, you need to keep on board vancomycin. And that's the end of the lecture. I will leave it for the questions.